Hi everyone, my name is Amber and I'm going to go over a urinalysis today, which is also called. The objectives of this talk is to describe what a urinalysis is, each part of the UA, and what the results might mean for your patient, or how to interpret the results of a UA. So to start, what is a UA? A UA is the analysis of a patient's urine through visual, chemical, and microscopic evaluation. So why do we get UAs? UAs can be helpful for diagnosis of a variety of things, including UTIs. They can also help rule out UTIs in our elderly population that might present with altered mental status. A UA can also help diagnose calculi or even malignancy as well. So the first thing to discuss is specimen collection. The clean catch is the most accurate way to collect a UA, and this involves catching urine midstream to avoid any external contamination or bacteria that can alter the results of the UA. This is ideally taken with the first urination in the morning, and some facilities might require the use of antibacterial wipes to decrease the rate of positive results from a UA. However, there has been no clinical benefit shown to using the antibacterial wipes. The second most important thing to know is where your specimen is coming from, especially if it's coming from a catheter. So patients that have a chronic catheter can have bacterial colonization within 24 to 48 hours of placement of the catheter. So you'll want to consider, is the catheter new or is it chronic, and how accurate of results will I get from a UA in this patient. The UA is broken down into three major groups: the macroscopic analysis, the dipstick test, and the microscopic analysis. We will go through each of these tests and each result and go through what some of the disease states that might cause a positive test result in each of these categories. The first part to discuss is the macroscopic evaluation, which is simply a visual observation of the urine. So they look at both color and clarity. This test can vary significantly depending on the person and is a very subjective test result. So the first thing that we're going to talk about is the color. And a normal color will be anything within the normal yellow range. So if you're getting a test result that says dark urine or amber colored urine, you should consider that your patient might be dehydrated and is concentrating their urine, or they might have rhabdomyolysis, which are both reasons that you could have a dark or amber colored urine. Furthermore, if a patient has red urine, you might think that the patient is bleeding somewhere within their GU tract and that blood is tinging the urine red. Furthermore, there are a few other things to consider, such as medications and diet. A few examples that I pulled out for medications is things like rifampin, which can turn the urine red or orange, and then amitriptyline, which can turn the urine blue. That second part of the visual observation is determining clarity. So this test result can range from clear to hazy or cloudy. A normal test result would be clear. So anything within hazy or cloudy might signal an infection within the patient's GU tract. However, this is not specific enough to diagnose a UTI in the patient, and you should take in to account the remaining UA results as well as patient symptoms and history. The next major component of a UA is the dipstick test. This involves a plastic strip that is inserted into a sample of urine for anywhere between 30 and 150 seconds, depending on the brand of test that you get. That stick is then pulled out of the urine and compared against the key, which is usually available around the bottle that the stick comes in. It's important to note that this test is specific but not sensitive. The dipstick test can identify specific gravity, pH, leukocyte esterase, nitrites, hemoglobin, protein, glucose, ketones, urobilinogen, and bilirubin. The first test result of the dipstick is the specific gravity. The specific gravity evaluates the urine's osmolality as an insight to the patient's hydration status. So a normal value is between 1.003 and 1.030. Any result below this normal range would indicate that a patient is well hydrated and therefore has a slightly more dilute urine, where on the opposite end, any value above this range could indicate a dehydrated patient that is concentrating their urine a little bit more. A specific gravity typically fluctuates over time and throughout the day. So if you happen to notice that a patient is getting a repeated specific gravity level of 1.010, this might indicate that a patient has intrinsic renal insufficiency, given that the specific gravity of the glomerular filtrate is 1.010. So this does happen to be within that normal value, but that will be a consistent number over time. A normal urine pH can range from anywhere from 4.5 to 8. However, a vast majority of patients will sit with a urine between 5.5 and 6.5 on the more acidic range of the pH scale. Typically, urine pH can be used as a representation of serum pH. However, there are a few disease states that can alter the urine pH alone, so those will be discussed at this point. So the first one is renal tubular acidosis, which is where patients are unable to acidify their urine. This would mean that their urine pH would typically be higher on that scale, if not above that normal range. Additionally, patients with uric acid calculi might have a lower urine pH, so lower than 4.5, and that could help diagnose either of those or just something to consider if that pH is out of range. Leukocyte esterases are not normally found within the urine, so normal test result would be negative. If it happens to be positive, infection should be considered. So leukocyte esterases are released from neutrophils, and the presence of neutrophils could indicate either pus or an infection. So that could help lead you towards the diagnosis of a UTI. Nitrites are similar to leukocyte esterases in that they're not normally found within the urine, and their presence could indicate presence of an infection. So nitrites are produced by bacteria that are able to reduce nitrates to nitrites. And most of these bacteria are gram negatives. However, there are a few gram positives that can also perform this reduction. This test is highly specific but not as sensitive, meaning that it can definitely determine the presence of bacteria in the urine. However, if the test happens to be negative, it not necessarily rule out an infection or a UTI for. Hemoglobin is another item that is not typically found within the urine, so a normal test result would be negative. If it is positive, there's a variety of causes that might have led to hemoglobin being in the urine. These include rhabdomyolysis, a UTI, renal stone, or even trauma to the GU tract. One important thing to note about this test is that it not only tests for hemoglobin but also myoglobin. So the test result will show up for hemoglobin alone, but it is important consideration that there might just be myoglobin present in the urine and actually no hemoglobin present. Protein is yet another item that is not normally found within the urine. If this test result happens to be positive, it could indicate renal disease. The glomerular capillary is only permeable to low molecular weight proteins at baseline, which should limit the amount of large proteins in the urine. This test is specific for albumin and light chain immunoglobulins, which would be considered to be heavier chain proteins and should therefore not be present in the urine. So things to consider might be renal disease, but also could be due to damage from medications, and even stress or exercise can lead to protein excretion in the urine. Glucose is normally filtered and then reabsorbed in the kidney. So patients that have a positive UA test result for glucose could be hyperglycemic. In this case, the patient's blood glucose is so high that it's overwhelming the kidney, and the kidney cannot reabsorb all of the glucose and is therefore getting excreted in the urine. The other alternative is that there's proximal tube dysfunction, where the kidney is not capable of reabsorbing the glucose and it all is all just simply getting excreted through the urine. The final part of the UA is the microscopic evaluation. This happens when 10 to 15 milliliters of urine is centrifuged, and then the sediment is resuspended and placed on a slide, and then the slide is placed under a microscope where the evaluation takes place. This portion of the UA can identify white blood cells, red blood cells, bacteria, squamous epithelial cells, as well as crystals and casts. The first one that I'll talk about is the presence of white blood cells. A normal result for this in men would be less than 2 cells per HPF. In this case, HPF stands for high-powered field and is also represented by the area visible under one frame of the microscope under the highest magnification. So basically what I've provided for you on the slide is an example of 1 HPF. So as you can see on the slide, there's about 6 cells that could be identified, so then that would be 6 cells per HPF. So in this case, white blood cells, men would have less than 2 in that one visual field, and women would have less than 5 in that one visual field. Any higher results than that could indicate an infection, and a UTI should be considered as a possible source of. Similarly to the white blood cells, red blood cells can also be identified. It's not normal to have red blood cells within the urine, so normal reading would be between 0 and 1 cells per HPF. Any sort of presence of red blood cells could indicate either infection or trauma in the GU tract, including UTI, renal stone, malignancy, or even sickle cell anemia. There's quite a variety of reasons why there could be red blood cells. Bacteria is not normally found within the urine either, so a normal result should be negative. However, there are some bacteria that can be identified under a microscope, such as staph or strep species. At this point, I would like to bring up that bacteria presence does not necessarily mean that a patient has a urinary tract infection. A patient might have a positive bacteria result with an asymptomatic bacteriuria, or could have colonization from an indwelling catheter. To put this in a little bit of perspective from the HPF fields that we talked about earlier, about 5 bacteria in one of those visual fields would represent about 100,000 colony-forming units, which is the classical amount of bacteria present that you need to diagnose a asymptomatic. Squamous epithelial cells are not normally found in a UA, so any sort of positive result here would be more than 2 cells per HPF. These cells are found on the surface of our skin, and therefore a large amount of squamous epithelial cells in a UA would represent a contaminated urine sample. If a patient happens to have a contaminated urine sample, you can still read the UA, but also take into account patient's symptoms and history before diagnosing something like a UTI, because it could be falsely positive. Crystals are not normally found within the urine. However, if they do pop up positive, they can be helpful for diagnostics, as they can give you the source of where those crystals are coming from and what is forming those crystals, such as the calcium oxalate crystal or uric acid crystal kind of gives you an idea of what's forming the crystal and what might be the cause of the crystal formation. So casts can be similar to crystals in the fact that they're not normally present in the urine. However, when they are, they can be helpful for diagnostic purposes. So I've listed a few characteristics. It's not an all-inclusive list, but I wanted to go through a few examples of types of casts that might be listed in a UA and what those might represent. So a hyaline cast is generally nonspecific, but is most frequently associated with dehydrated patients. A brown cast is usually suggestive of an acute tubular necrosis. A waxy cast can suggest kidney disease, and a fatty cast can suggest a nephrotic syndrome. So there's a variety of characteristics, and they can each represent a different diagnosis or something else to consider for your patients. The last thing that I wanted to go through are some medications that may affect the results of a UA. So the first test is the bilirubin, and a false positive might be seen in a patient that is on phenoxypyridine, and a false negative could be seen in a patient that's taking chlorpromazine or selenium. Similarly, the glucose test could read a false positive on a patient on levodopa and a false negative on patients that are taking vitamin C. The ketones test could read a false positive for a patient on Mesna. The leukocyte esterase test could read a false negative for a patient that's on cephalexin or nitrofurantoin or vitamin C. The Nitrites test could read a false positive for a patient on phenylxypyridine or a false negative on vitamin C. And the specific gravity can be altered by dextran solutions. So overall, I would say the largest impact could be the false negatives from patients that are regularly taking vitamin C as an over-the-counter medication. This concludes the video.